I lead this wonderful organization, the IHI, that has partnered with the British Medical Journal, BMJ, for now more than almost 3 decades. And we have brought an unbelievable conference of innovators and creators and health system transformers together, improvers, to talk together about what it's going to take to change our health systems, create better relationships both within our health systems and between our health systems and our communities, and to build a better healthcare world.
So it's probably fair to say that across most of the world, healthcare systems have had a bit of a kicking over the last 4 or 5 years.
Indeed.
One of the themes of this conference is the idea of regenerating healthcare. For you, what do you think healthcare needs to regenerate from, and where has healthcare had some of the greatest kickings during the pandemic and beyond?
I think we sometimes we overstate the challenges that our health systems face. The truth is that we get a lot of things right. Yesterday evening, I heard a story about someone here in South London who had a facial droop, and within 5 minutes, the ambulance had come, had taken this elderly woman to the hospital. She had had a scan within 30 minutes, and she got clot-busting medicines to improve her, to really save her from a stroke within 30 minutes of having symptom onset. It's just we forget the magic of the NHS, and all of our health systems at times create these amazing results. We do, as improvers, we naturally focus on some of the challenges that we face, and we have had incredible challenges over the last really many years. The pandemic, of course, being a big one, but that has had enormous impact on our systems, not just in terms of the pandemic itself, but also our workforce has been challenged. The burnout that our workforce has experienced has been really a different epidemic that's been occurring at the same time as the pandemic. Challenges around equity, challenges around relationship, building trust within communities and between healthcare and the communities of service users and patients and families that we hope to serve. Those have been adjacent crises, parallel crises that have been occurring, and that we need to build our system to even better to solve those persistent challenges that we had for a long time.
So we're here and we're going to be talking about quality improvement for 3 days, which is kind of pretty amazing. As you say, there's lots of things we get right. Quality improvement is kind of the science of noticing what isn't going quite so well and then changing it. Like, what would your message be to someone who's kind of outside of the health and social care, quality improvement world? How do you think about quality improvement beyond just don't make mistakes and do things better?
Yeah, well, so I think, in some ways quality improvement for me is all about learning. It's all about changing. It's about an active way for systems to continuously change. And if I'm outside of healthcare, or if I'm a service user, I want my system to always be getting better, right? Just as you want your children to always be learning, and you want your airlines to always be getting better at making sure they don't lose your luggage. You want your health system to be continuously learning, continuously improving, continuously transforming, continuously innovating, and that's what quality improvement allows us to do. It allows us to take a system and actually make it better and better and better and better, so that it can take better care of all of us in some ways. And so from my perspective, you want QI, you want quality improvement to allow your system to continuously learn and improve.
Hopefully you didn't lose your luggage. I was just thinking as you were saying that. So it sounded a kind of heartfelt, personal experience there. So I know that you're going to be giving a keynote on Thursday morning. Not to steal your thunder at all, is there anything you can kind of share about what you're going to be talking about on Thursday morning?
Well, I'm so pleased that the colleagues here at the BMJ and in the NHS and at IHI have focused the first keynote on health equity. From my perspective, as I began this role, I started as a president of IHI in 2020, and I made it part of my mission to connect quality to equity and vice versa.
Can you explain for someone who's maybe not so familiar with those terms what equity in a kind of health and care context means?
So equity for me means making sure that all individuals, patients, families, service users, everyone has a chance, the best possible chance of achieving their maximum health potential, regardless of their social situation, their racial background, whatever disabilities they may come into the situation with, that they have the best ability to reach their full health potential, and that we should build our systems to allow that to take place. That's what, from my perspective, health equity fundamentally means. And it means building the system differently so that we can actually reach the most disadvantaged, the most vulnerable, the most people living in deprivation in a very different kind of way.
So we used to talk a lot about kind of health inequalities.
Yes.
Is there a difference between health inequalities in discussion and health equity?
Yeah, we have a tendency to use the terminology equity rather than equality or inequalities. Equal tends to mean you're giving everybody exactly the same thing. And the truth is that if you've had centuries in some cases, or at least decades of structural injustice or oppression or racism or marginalization of some kind, giving everyone exactly the same thing means that you'll still perpetuate those inequalities in your system. We've been trying to reduce unequal treatment for decades in some ways, and I think that's been part of the challenge for us. So we actually have to think about an equity approach, which means giving people exactly what they need so that everyone can reach their maximum and full health potential. And that's a fundamentally different concept than equality. So we've now begun to think differently about the challenge of achieving more health for everyone, and we've used an equity framework rather than an equality one. We're not trying to give everyone exactly the same building blocks. We're actually trying to ensure that we are focused on the challenges that people are experiencing and then give them exactly what they need to be able to reach their full health potential.
So in that way of looking at it, the communities in which healthcare services are physically, politically, socially located, the community is a kind of big element of that, a big kind of player in that. But the community is not part of a healthcare system. The community is just people doing things that they do every day. Do you think there's a tension there?
So I think actually the community is part of the health system. It's just that we've not welcomed the community into the health system. The community's always been there, right? Our health, your health, my health, each of our health is determined not by what the healthcare system delivers to us individually. It's determined by how our community shapes our social circumstances. It's determined by a whole lot of other factors. In fact, the literature suggests, the evidence says that the factors outside of what you get inside of hospital matter far more to whether you're going to have a healthy life expectancy than whatever happens in the hospital. Now don't get me wrong, if you're having a stroke or you're having a heart attack, you need the hospital to save your life and to make you healthier. But in the broader picture, your risk of having a heart disease or your risk of having a stroke in the bigger picture is entirely related to the way in which you're brought up. It's related to what you eat. It's related to the job opportunities you have. It's related to all kinds of things in the community. So in my view, the community's always been present in our health DNA, but we haven't, as a system, as a healthcare delivery system, we haven't found ways of integrating health in the community with what we deliver inside our institutions. And that's what we're trying to change today.
It feels like a big challenge at the moment because outside of the healthcare system and within the healthcare system, people have been through a lot.
Yes,
and communities have been through a lot.
Communities have always been through a lot. The truth is that communities, especially those living in deprivation, who have been historically disenfranchised or marginalized, those communities have been suffering in relative isolation or through deprivation for decades, sometimes centuries. And so that suffering, that challenge is not at all new. So for us in healthcare to say, to create an environment that's welcoming for the community, to build trust and relationship is something it is our job to go reach out to the community to make that happen.
So my kind of devil's advocate question is, what happens if, for historic reasons, the community doesn't want you?
Keep trying. Yeah, I mean, the short answer from my perspective is that suspicion, distrust, mistrust, whatever word we want to use to describe sometimes the reaction of community to our outreach as healthcare is very sensible. Again, marginalizing, sometimes deliberately, communities for years, decades, centuries, you can imagine would build up considerable distrust, mistrust, or suspicion. So from my point of view, our response to that as healthcare and as system leaders and as folks that have a considerable amount of power in the system, our response to that has to be to continue to reach out. It's hard, to be clear. It's not going to be easy when you face initial rejection or initial distrust when you experience that. But that is the story here. We have to acknowledge, first of all, I think there's a really clear approach to how you work with communities. You acknowledge that history, actually. You start by acknowledging that, and in some cases apologizing for it, even if you weren't part of the centuries of oppression, because you haven't been around for centuries. Yeah. But still, the act of generating an apology and an acknowledgement of the suffering that a community has been through, that's a trust builder and a beginning, an entry point into the conversation. Yeah. So that beginning of acknowledgement and apology in some cases leads to the possibility of understanding, which leads to the possibility of making improvements in the system, redressing the historical acts that have led to ill health in communities. And then I think you have to go back to the community and ask whether your solution was adequate. So I think too often we design our solutions in conference rooms or even in meetings like this, and we don't actually go back to the community to say that the solution that we created solved the problem that you initially identified. That act of going back to confirm that we've actually done the job that we hope to do is something that I think is, again, a trust builder. So we have to this is not going to be a one-time experience.
Decades, isn't it?
Yeah, it might. I don't know if it'll take decades to create some form of restoration, some form of regeneration, as is the theme of this meeting. I think it's going to take authenticity. I think we have to authentically be, we have to be serious and authentic about our desire to create more health equity with our communities. We have to create an environment that is welcoming. We have to create acknowledgement and understanding. And then we have to get to work and actually start to improve even something relatively small, which can be improved relatively quickly. And I'll talk about tomorrow in the speech. I'll give multiple examples of how quality improvement work, the methodology that we're gathered at this meeting to learn about, has in fact created more equitable care outcomes with communities on specific health conditions around the world. That is very possible, but you're going to need to do that. We are going to need to do that over and over and over again in consistency, in an authentic manner, and those are the kinds of things that I think eventually build relationship, it builds trust, and it builds connection. And I think at that point, then we'll have a very different kind of conversation about how community and healthcare should be working together.
So just to tie us up at the end, because you're a keynote speaker, you know lots of stuff that's happening in the world. What's your favorite example of that kind of authenticity and that kind of relationship building? Because everyone has one thing where it gives them the chills when they think about it.
There's this amazing example, in my view, of a health system in Atlanta, Georgia. This is from years ago, called Grady Hospital. Grady is a large, what we call in the US, a safety net hospital. It's a public institution, heavily visited by people from the community. Many of their patients are very marginalized, deprived, they just don't have a very poor background. And Grady, because of the way that we pay for healthcare in the U.S., was going under. It was actually struggling to keep pace financially. And Grady launched a campaign that said, "I'm here because of Grady," with patient pictures of community members whose lives had been saved by Grady. And that was a way of creating a restorative connection between this institution and its community that led to people realizing how vital Grady was to the whole health system, to the whole, not just health system, but to the whole ecosystem of the city of Atlanta. And that kind of connection built authentic relationship between the health system and its community, and led to eventually the restoration of Grady and 10 years later, maybe more than that now, 15 years later, Grady is now at least a thriving institution in that community and has created a very different kind of relationship with its community.
So, final question.
Sure.
Is there anything that you really, really, really want anyone watching this video to get into their heads, to really get into their hearts around health equity, community, any of those things?
But I think the thing I really want people to understand is that health inequities or health equity is achievable. You know, we can make some of these very troubling statistics. We spend a lot of time on documenting the problem and admiring the statistics and admiring the problem, as some people call it. Yeah. We spend a lot of time on that. But the truth is we can actually do something about it. And the methods that we are here to explore, quality improvement methods, change management science, these methodologies, which are designed to eliminate inequalities, are actually very, very effective at reducing inequities. So even though these things have been baked into our systems for generations in some cases, we can actually use the power of quality improvement and change management to change the system as it is and to create more health equity. And so that's my hope that people will come away from this with is not a feeling of looking at these staggering statistics that have been around for centuries and saying, what on earth can we do about this? But getting started on actually making a change in our systems.